Right then, hello, good evening. My name is David Shipway, and I'm a geriatrician perioperative physician in Bristol. And I've been asked to talk to you this evening about the sort of older surgical anaesthetic patients and issues relating to that for the forthcoming exam. So just to recap broadly what my remit is, what I'm sure many of you will be familiar with is the fact that recognising and managing the perioperative complications in sort of older patients and recognising those needs of older people and frail people is only literally one line in the official curriculum. So it would be entirely reasonable to consider that this was not a huge deal. But hopefully many of you will already have realised that the older frail surgical patient is also the high risk patient. And therefore, lots of what we're going to talk about now is really about management of high-risk individuals in the perioperative period as part of the sort of whole perioperative medicine curriculum. So hopefully you can see that there's a slightly wider remit than would normally be the case. So what I'm going to talk about in the course of the next half hour or so is what's sort of special about older people. I'm going to talk about what defines a high-risk patient, talk about multimorbidity and frailty and the physiology relating to that. And then most importantly, really for sort of vital opportunities at the examinations, think about what we can do about that. So think about what optimal management of the frail older anaesthetic patient is in terms of careful risk assessment, communication of that risk, where necessary, assessment of mental capacity, a quick revision there for you. Talking about careful consent in the modern era of Montgomery, and then about medical optimization and the issues that we face in regards to evidence and what we should do currently as part of best practice. So to begin, what's special about older people? Okay, so this is data here that you can see from TARM, the Trauma Audit and Research Network. And admittedly, you can say, well, this isn't specifically anaesthetic, but it kind of is, because older trauma patients have a lot of emergency surgery and they also go to intensive care unit. And I'm well aware that many of you will perhaps be dual accrediting in ITU as well. So these are patients that are particularly relevant, I would say, to an anaesthetist or intensivist. And what you can see, the striking obvious abnormalities here are the precipitous rise in mortality with advancing age, going from sort of young adults who have less than sort of 10% mortality from major trauma to those in their 80s and 90s who are clocking around 30%. And what's also important is this sort of grey line, which represents good functional recovery. So it's not just about death, it's also about who does well after these injuries and who makes a good recovery to independent living. And again, you can see that the majority of fit younger people under the age of 60 do well. The 16 to 59 8-year group, about 55 to 60% of those make a good functional recovery after major trauma injuries. Whereas those in their 80s and 90s, perhaps only about 25 to 30% make a good recovery, okay? And so what that tells us, of course, is about the trajectory and what this means to older people. And this data could easily be reproduced in a number of different surgical settings to deliver the same message. But this particular figure has them both on the same axis, so it's particularly nice from my perspective. But the same message applies here. So this is data from NELA, emergency laparotomy, again, raw mortality, very substantial for people in their 80s and 90s, around 25–30%. And you may well say to me, well, it's just emergency surgery that we're talking about here. But this is data, again, from the elective surgical sort of literature, admittedly a few years old now, getting on for nearly sort of 15, 20 years. But it gives you the overall message, doesn't it? That mortality rises with advancing age in elective surgical settings as well as in emergencies. So this is a problem across the board. And something that we can't really get away from. And we know, of course, from decades of research and experience that the presence or absence of complications is really important, isn't it, in terms of determining what happens to older people. So those that suffer from complications go down this slippery path of complexity and adverse outcome, and they take longer to recover, they have longer length of stay and increased functional decline, whereas those that swim through and do really well discharge quickly without any further issues. So the presence or absence of complications influences mortality, as we know, and also functional recovery. But what's really, really important to look at specifically is what those complications actually are. So if you talk to your colorectal surgeons, the ones that I deal with on a regular basis get very twitched and very concerned. What if, David, what if she gets a leak and I have to take her back to theatre? She won't survive that. And I have some quite entertaining sort of, Irish anxious, colorectal surgeons that I work with. But if we look at the data here, what we can see here is these anastomosis failures, are actually not particularly elevated from this colorectal series here with advancing age. But what was striking, of course, is the increase in medical complications, okay? So we've got a rise in respiratory complications from 5 to 15% in younger versus older patients, cardiovascular complications, arrhythmias, events, 0.8% to 4%, neurological complications, TIA, stroke, delirium and so forth, going from 0.2 to 1, and VTE risk also rising. So these are medical complications that these patients are suffering from in older age, rather than those sort of classic surgical things that we sort of fear and what surgeons fear and which make the sort of headline topics in the consent form. And when, of course, these patients get these complications, and it means that they spend, a week in hospital with a pneumonia, an AKI, perhaps a bit of, troponinitis, after surgery, and they don't get out of bed because they're a bit sleepy, a bit unwell, and not very steady. And everyone just says, "Oh, just sit tight there." Not one for enhanced recovery, because they've just had a troponin rise of 300 after their op, and they're a bit tachycardic with their fast AF. What happens, of course, is illustrated by this figure here. Now this is a picture from my brother, who is an emergency medicine registrar in Western Australia. And he was unfortunate enough to be playing beach football, I think sometime last year, and ended up rupturing his anterior cruciate ligament and ended up spending, I think, some days in a sort of special cast. And what you can see from this figure is that his right leg has completely shriveled up and wasted away during a mere 18 days of wearing a brace, despite the fact that he's hobbling around on crutches. And that is entirely in keeping with the physiology literature that we know, which states, of course, that muscle strength can fall by up to 40% with 1 week of disuse. So this is what happens to a fit young man's leg after immobility. If you put an old person in a bed on the intensive care unit for 10 days after emergency surgery, or even in a hospital bed where they're not getting out, not being ambulated, not being sat out, you're going to see this sort of muscle loss across all organ groups, not just across limbs, but also torso. And this, of course, is resulting in global sarcopenia. And it's the basis, it's the physiological basis for functional decline, which ultimately is represented by not being able to get out of bed after the medical complications are over, not being able to walk out of the hospital, requiring a long length of stay, rehab, demand for community services and so forth. And it's obviously what crucifies hospitals over winter, because people don't get out and don't leave. And of course, I'm just presenting data here really just to illustrate that point, that these patients who get complications are the same ones that have complex adverse discharge. And so it has a massive system-wide effect. And this deterioration that we see, it lasts for a long time. So it doesn't just disappear after 2 weeks of rehab. It may last for months and months, and perhaps in some cases even permanently after major complex surgery when things have gone wrong. And these factors are obviously really important to older people because they make a big difference to whether they have a decent quality of life and can live independently, and therefore they're also important from a consent perspective. But why is it that older patients suffer from these complications? So we've seen that they do badly, we've seen that they have high rates of mortality, we've seen that they get complications and functional deterioration. Why? So the first thing to obviously state is it's partly about medical comorbidity, and that is illustrated here by this figure on the left, which as I'm sure some of you have seen before, is derived from decent, I think, Scottish data actually, but it was published in the Lancet 2012. And what you can see here is that people in their 70s and 80s, it's entirely normal for them to have medical comorbidity, and not just 1 or 2. So most of these people will have 3, 4, maybe even 5 medical comorbidities, and that's not particularly remarkable. And so it's no surprise, is it, that these people are likely to get complications relating to those comorbidities, be they heart failure, COPD, hypertension, renal failure, or congestive cardiac disease. And we know, of course, that medical comorbidity, once you start accumulating those 3 or more, it starts to become significant and increase your mortality risk, which is illustrated by those figures on the right. But it's not just about comorbidities specifically. The physiology of aging is also really, really important. And this figure here, it rather nicely sort of collates a number of different parameters of organ function into one particular set of axes here. And you can see conduction velocity, metabolic rates, cardiac index, eGFR, vital capacity. So parameters of all the major organs. And what you can see here is the trajectory of decline with advancing age. And when we have, physiological changes like this over advancing age, in a number of different organ systems, that fundamentally is the basis for the frailty syndrome. So frailty really is characterized by this reduction in physiological reserve across multiple organ systems, meaning that there's a homeostasis, a failure to be able to adapt to changing physiological stimuli and scenario, and a risk of breaking out finally into overt organ failure one way or another, which, of course, as a common complication we see to one extent or another in the older patient in the postoperative period, be that respiratory, renal, or cardiac, or brain in the context of delirium ultimately being a brain failure. And frailty is something we're going to talk about now just for a minute or two. Now, I realise it's beyond the remit of this particular talk to discuss frailty in all its glorious detail, but ultimately it's a syndrome that represents accelerated ageing. For reasons that are not entirely understood, but they probably have a basis in endocrinology, a basis in nutrition, and a basis in inflammation, and maybe perhaps partly driven by some of the interleukins and TNF-alpha having an effect on metabolism, cell breakdown, and so on and so forth with advancing age. So the point I'm trying to make here is we will probably, in the course of our working careers, be seeing more information and more explanations relating to frailty and potential interventions that are currently being done in animal models to see if the cycle of frailty can be intervened upon and reversed. So hopefully we'll be seeing more of that in the next few decades. But in the meantime, what's really important is to really conceptualize and understand what it means to be frail and then to be subjected to an insult. And this figure, of course, describes the differences in trajectory of outcome between a frail individual and a non-frail individual. So let's take A first. Line A is a red line. This is a robust, physically fit person, perhaps undergoing surgery or critical illness, you might argue, with the first insult, but probably more likely to be surgery, who takes a dip in their functional capability on the y-axis there, but it doesn't cross the line of functional dependency. And so they return very quickly and rapidly to their pre-morbid status without too much to do. And it's water off a duck's back for this sort of patient. So this is the sort of person who might have a short one-night stay in hospital or in a day case procedure. But a frail patient is perhaps represented by blue line C. And what you can see here is that same insult hits them harder, and it carries them down in physical functioning capabilities below the line of physical dependency. So they require other people to exist and to physically function. And it takes them longer for them to return to their pre-morbid baseline. And you can see out here that actually their baseline status may be a smidgen lower than it was before, at least for the duration of this x-axis here, although perhaps over time may increment back to where it was over weeks and months. What's really also important, though, is to understand and conceptualize line B, which represents the frail individual that's hit by a secondary insult, so a secondary complication in their post-operative period, which then carries their nadir even lower, and their trajectory of recovery, it becomes even slower, deeper, and their functional recovery also may well be significantly impaired. And so that's exactly what happens to our frail patient who has an operation, who then gets hit with a major post-op complication like pneumonia, acute kidney injury, or something along those lines. But when we talk about frailty, it's really, really important to be able to differentiate between frailty and old age. They're obviously closely linked. And historically, all the data I was presenting at the start talks about age as being the key deal here. What's really emerging in the literature is that age is becoming less important, and what's becoming really, really key here is actually frailty. So this figure here on the left, the guy who's running, the guy in the turban is a guy called Fauja Singh, and he's over 100 years old, and he runs marathons. I think he may have given up running marathons now because he's about 106, but the point being, he was still running the Edinburgh Marathon at the age of 101 or something, this particular individual photo. So he's old, okay, but he's not frail. He's physically fitter than me, and probably fitter than half the people listening, in terms of his ability to exercise and perform from a cardiovascular perspective. On the other hand, you've got a patient here, the late Baroness Thatcher, who's obviously now dead, but this is a figure taken in her latter years, in probably her early 80s. And you can see she can't even stand without the assistance of two people. So she's also old, not as old as Fauja Singh, but old, and she's defined frail, okay, because she's unable to manage independently. Okay, so this is really important to be able to differentiate the two, because if we don't differentiate the two and we assign risk and decision-making purely on the basis of age, we're going to be at risk of discriminating against the Fauja Singhs who are physically fit and can can undergo the physiological challenge of surgery, and potentially also underappreciate the risk of the relatively younger frail individual who's become prematurely frail for whatever reason. And so we have to be careful in the modern era to move away from using date of birth as this parameter of risk assessment, and to try and use frailty scores to be able to address what we really think is key here, which is frailty. So how would you do that? So the first thing for you to be aware of is that there are loads of different types of frailty scores. Some have been validated, some have not been validated in surgical settings. My personal advice would be to keep it simple and not try and get too clever. The American sort of frailty scores they tend to use tend actually to be more assessments of comorbidity rather than, and that's sort of things like the modified frailty index. And actually, we're actually currently working on some stuff we think from data we haven't published yet, but the modified frailty index isn't as good as the clinical frailty score at predicting adverse outcomes, which you'll see hopefully in forthcoming months. So we would recommend keeping it simple using the CFS. This is the clinical frailty score, sometimes called Rockwood, named after its sort of lead author, but the clinical frail scale is its proper name. And this is actually Canadian. It's derived from large-scale big data in Canada and been validated in loads of different clinical settings. It's also been validated, for research purposes in a retrospective setting. So it's really well used, and because it's so easy, it's got huge traction in the UK within medical settings, in ED, in medical admissions areas, and so forth, in community. Because of its ease of use, and literally you can just read down the grid to see which sort of characteristics suit your patient best, and there's even a silhouette to help you guide you if you're not even quite sure after that. So this is the easiest tool we think to use. Perhaps once you're familiar with it, it takes a matter of seconds really to assign a score, and it's been nicely validated. And I'm going to be cheeky and show you some of our own data to demonstrate the validity of the CFS in predicting outcomes at 1 year after major trauma. This is stuff from the Bristol Major Trauma Unit, from the same sort of data sequences that we were presenting other stuff from. And what you can see here, of course, is survival probability according to CFS scales. Okay, so what we can see here is those with a CFS of 7 to 8 at 1 year, about 50% chance of being dead after their injuries, but obviously those that are physically fitter have a much better outcome. And again, this is just illustrative. It's a nice picture with some sort of rainbow colored lines on the chart, but we could present very similar data for other surgical types and other surgical settings, emergency and elective. And you'll find that CFS is emerging as sort of leader of the pack in this particular setting because it's so easy to use. Other scores, of course, exist, and this data here I've just included here just to illustrate that it's not just about mortality. Frailty is also really important in terms of determining length of stay for the reasons that we talked about with functional decline, readmissions, and also global overall healthcare costs within the wider healthcare setting. So frailty is emerging as sort of king in terms of the sort of geriatric risk assessment and what it means in a wider healthcare setting, of which part of that is perioperative. And what, of course, is the bottom line? So, of course, what we know from epidemiology of populations is that we've got an aging population. That much, I'm sure, is already very familiar to you. In terms of having a number in your head, 10% of the population in the UK is going to be aged over 80 in 2050, according to current projections. And what we know about what's happening to health is that people are living longer, but that is not with compressed frailty and dependence at the end of life. It's actually just extended over a similar period. So we're not saying that people have the same amount of disability. Their disability period is probably being extended as well as their longevity. Okay, so whether that's a win or not is another question for another day. But the point of the matter is that there's a lot of old people that are going to be around, and a lot of them are going to be frail. Probably more of them are going to be frail, and they're going to fall over, break their hips, get subdurals, and they're also going to develop things like cancer because they're getting old, maybe around for a while, and arthritic disease and so forth, which will be indicated for the purposes of trying to maintain independence and keeping social care costs down within the wider health economy. So this is going to become an emerging problem, even more so than it already is. So what should we do about this? Well, I mean, you could take the view and say, well, the risks of operating on frail people are really high, so maybe we shouldn't do it. But let's be honest, is that realistic? Are we going to be able to say that citizens are not going to be eligible for surgery on their hips, on their knees, for cancer and so forth, just because they're old and frail and at high risk? Is that going to be justifiable? The honest truth is it isn't going to be justifiable to the electorate, and as politicians set policy, so we will follow. So we're going to end up operating on these people. And the question is, how are we going to do this appropriately? So we're going to need precise and careful risk assessments. We're going to need, obviously, informed consent for the adverse outcomes that are going to follow in a population that is high risk. And we need to do what we can to minimize those risks by a process of optimization. So how do you risk assess? So what we do and what we use in Bristol in our sort of high risk geriatric preoperative assessment service is a comprehensive geriatric assessment, which means detailed history, functional assessments, stuff that's beyond the remit really of an anaesthetic clinic, because we have more time to do it as physicians than our anaesthetic colleagues, and a proper CGA type methodology to make sure we've kind of covered all the ground and we know whether there's active medical conditions that need to be addressed and attended to. And at the end of that, what we do is we generate a risk assessment using our favorite tool at the moment, which is the American College of Surgeons NSQIP surgical risk calculator. Now, obviously, there are loads of tests out there, SORT, POSSUM, various ones that you could use. But this is our favorite because it feels about right in terms of the numbers that come out. I'm sure all of us have calculated POSSUM scores, calculating 80% mortality for certain sort of situations, particularly emergency laparotomy, and we go ahead anyway, they do fine. And after a few days on ITU, they're out and they do pretty well. And it just doesn't feel realistic. It doesn't feel like it's appropriate. And I think when people stop believing the figures that are generated by these risk prediction calculators, they cease to have value, unless, of course, you're trying to present a case not to operate on someone, which, of course, I've seen happen too. So this is our favorite tool at the moment. It's available, obviously, on the internet via Google. And what's great about it is it offers a specific operation. At the top, you have a drop-down list of lots of operations where you can select out keywords. And most of the ones that we want, you find. Sometimes you have to approximate slightly. And then, obviously, the risk factors. And the great thing about it, of course, is that it allows you to generate not just a mortality risk, but specifically complications, certain types of complications, and also, really importantly, discharge to nursing or rehab facility. Now, I always caution my patients in relation to this because this is American data, and obviously the social sort of situation is slightly different in that regard, with lots more people probably going out of hospital earlier to some sort of institution for rehab than would probably be the case in the UK, and that's why we probably have a slightly longer inpatient length of stay. But I think what it tells us, of course, is this is functional decline after surgery, people not bouncing back and making a good recovery. And what I counsel them for is to say this is the sort of, the risk of you not being the same again, at least for a period of time, or perhaps needing care and support at home to continue to exist in your own home. And I think that is a bit of useful information that sometimes is a deal breaker when we're talking to patients to help them come to terms with whether or not they should undergo surgery. But whenever we're talking about an operation or operating an operation, this is going to the sort of pre-op sort of aspect now. You've got to offer the alternatives, okay? A choice is only a choice if one has a clear vision of what the alternative option will be. And that involves this balancing the risks and prognosis, both with and without surgery. And this is, again, hopefully helpful for those of you with a POAC interest. But to be able to do that, of course, you've got to know and understand a little bit about the natural history of the surgical disease and indeed life expectancy at various different age and medical comorbidities, to be able to give an individual and their family a view on what the relative options look like. And that, of course, is difficult, and no one can do everything. But of course, with an increased sort of experience in a little subfield, so for example, vascular anesthesia, cardiothoracic anesthesia, colorectal, whatever, one will come and become part of that, particularly if one has the ability to attend MDTs and learn a little bit about surgery and the medicine that goes with that. I think it's really important to think about life expectancy when you're seeing the older surgical patient. So you might well say, well, where do I find that out? Well, Office for National Statistics publish life data tables every few years. And we're really bad intuitively guessing what life expectancy is for people of certain ages. And this table here gives you the figures for various different ages, just randomly plucked out for 2014's tables. They've been updated now, I think, to 2019. But what you can see here is that even if you're 90, you've got a life expectancy somewhere between 4 and 5 years, okay, as a man or a woman. And if you're 85, it's 6 or 7. And that's going to be kind of important, isn't it? If you're faced with, let's say a rectal tumor, which is quite big, a T3 or something like that, that's at risk of causing an obstruction, and someone needs to talk to you about whether or not to take it out or to do something from a defunctioning perspective. Because what we know is that if you're a fairly average 85-year-old who's just been diagnosed with a T3 rectal tumor, it's probably going to catch up with you in your natural life expectancy, isn't it? Because, 18 months, 2 years for that tumour to grow, cause metastatic disease and cause you to die, or worse still, obstruct and develop, nasty bowel obstruction. That's probably going to happen within your natural life expectancy. So you may well therefore be more inclined to accept an elevated risk operation on this basis. But the problem, of course, is that these are average population figures. So they don't account for disease states. They don't account for the sort of person that you see in a complex vascular clinic who's got, who needs to have, an aorto bifem bypass because they've got terrible, COPD, smoking-related disease, ischemic heart disease, heart failure, and all of the above. Those figures are not going to be applicable. And so you need some way of adjusting those figures for those various different disease states. Now, you can go on PubMed and you can look up, epidemiological data indicating, what the effect on overall life expectancy is for peripheral vascular disease or heart failure or COPD. But it's quite a struggle to find data for what if they've got them all, and that becomes a real problem. So the way we deal with that in our sort of, geriatric high risk assessment clinic is to assess life expectancy on the basis of frailty. And frailty this is epidemiological data from the UK, which of course makes it far more relevant to our practice and less subject to debate about how applicable that would be if it comes from North America. And what you can see here is that at various different ages and degrees of frailty, and I'll come on to how you calculate the EFI in a second, on this figure on the right, you can work out how long someone is likely to live. Okay, and that is far more accurate and feels real from our own experience of working with these patients within a UK sort of setting. And this is brilliant because the thing about a frailty index like this is that it's derived from primary care data. So the EFI, the electronic frailty index here, is derived from primary care read codes. So if you ask a general practitioner for a frailty assessment, they have a little button on their sort of electronic case notes desktop, and that can generate a figure. Many of them will already have it. It just will bury it in their sort of GP summary printout, and that will generate the figure for us from these various lists of 36 deficits in the box here on the right. And you'll see that some of those deficits are specific medical comorbidities, valvular heart disease, heart failure, respiratory disease, diabetes, CKD, stroke, AF. But then some of them are also functional, like activity limitation, mobility and transfer problems, sort of things that we see in our frail patients. So they encompass the whole picture of the patient, specific key core medical comorbidities, but also functional stuff. And that's why this is brilliant, because it captures a holistic view of the whole patient. And it seems to be accurate, seems to work, and we believe it from the point of view of the medical predictability of life expectancy. So I think it has a lot of value in the perioperative setting too. So let's give an example. This is the sort of patient that we might see in our high-risk patient sort of clinic. And this is a frail 82-year-old presenting with a 6.5 centimeter aneurysm being considered for EVAR. And the risks of rupture on an annual basis that we've been quoted from the AAA literature, about 6 or 7% per year. And our 82-year-old is presenting. And the NSQIP tool that we've run for him, given his medical comorbidities, is coming up with quite a high risk here. Mortality at 8%, complications at 22%, and discharge to long-term sort of rehab at 40%. So there's obviously something going on with this guy, which I haven't disclosed to you here. But you might well take the view, if you look at his life expectancy, he's got officially at 82, he's got a life expectancy of 8 years, so he's got 8 years and he's got a 5 to 10% rupture risk right now. Again, this aneurysm is quite probably going to blow or cause him some serious problems in the course of his natural life expectancy, if you believe the Office for National Statistics data, which of course, as I've alluded to already, isn't that reliable for people like this. Now, if you then rescore his life expectancy using the electronic Frail index, what you can see is life expectancy is actually 2.5 years. And of course, the clue to that was in the fact that his mortality for EVAR was 8%. There's stuff going on here that we haven't disclosed. But the point I'm trying to make here is that, if you get the wrong numbers from the wrong sources, it leads you down the garden path to the wrong conclusions, or can lead you down the wrong path to the wrong conclusions. So you need to know where you're coming from and make sure you've got the right people. And that partly, I suppose, is why our clinic exists, to support anaesthetists in these sort of complicated situations, and surgeons, of course, anaesthetists and surgeons as part of a wider surgical MVT to make the right calls in these sorts of patients and to cherry pick out the right patients who are likely to benefit from surgery and not operate on those that are unlikely to. And I think I do a bit of medical legal work in my sort of other time, and I'm interested obviously in the issue of consent. I think we're probably likely in the future to see quite a lot of this in the older surgical patient coming forward following Montgomery versus Lanarkshire. And I don't know whether you guys are familiar with this, but the key point here is that we have now a case law duty to take reasonable care to ensure that a patient is aware of any material risk. Now, any material risk indicates anything that is likely to be considered to be significant to the patient. Okay, so Montgomery versus Lanarkshire was an obstetrics case where I think it was shoulder dystocia wasn't properly explained as a risk of delivery for a diabetic mother who had a large baby, and as a result of that, she tried to have a natural delivery and ended up having breach, and baby had hypoxic brain injury and cerebral palsy as a result. And she successfully sued the trust because she wasn't consented specifically for this particular issue at the time. And the key point here is that a lot of old people don't do well after surgery. They have functional decline, and that means they need expensive packages of care, and even worse, expensive nursing homes or residential homes after the care. Now, the cost of a residential home or nursing home is about £1,000 a week in my part of the world. In London could easily be £2,000 a week. So you can imagine if you're a self-funding patient, that's the sort of thing that's going to upset the relatives of this particular older person that had an operation quite considerably if they're forking out £1,500 a week on care for mum. And that means that if they weren't warned about these risks, I think we're going to see a considerable number of cases raised where there was a failure to adequately consent for this outcome. So I caution you about that, and hopefully you can take that away for your clinical practice, if not for the exam. Going back now again to risk, what if the patients don't get it? So what this brings me on to, of course, is the presence of undiagnosed cognitive impairment in older patients. And what we know, of course, is that in some particular case mixes, in particular vascular surgery, nearly 70% of patients that are seen in a pre-op setting who have screening for cognitive disorders, so not just a quick chit chat and all things didn't sound quite nice, so we decided to refer, but genuine, routine, systematic screening. What we found, or my colleagues in London, Drew Partridge and colleagues, found is that nearly 70% of them ended up with undiagnosed cognitive impairment. And that is massively important from a point of view of consent. And that doesn't necessarily mean that they don't have capacity. It just means that we need to be very careful about that. And I'm sure you're already very familiar with the issues surrounding capacity. But it's obviously being able to understand information, retain that, weigh it up, communicate the decision. And if capacity is absent, then of course we are obliged to follow the instructions of those holding powers of attorney for health and welfare. Where such attorneys don't exist, then we need to formulate a best interest meeting, and that will obviously be guided by friends, family, or if none are available, an IMCO. Elective surgery is going to be rare to operate on people who don't have capacity, mainly because dementia is, of course, a terminal disease with a limited life expectancy of approximately 5 years from diagnosis. So you're going to have to make a strong case to say that these sorts of patients should undergo an operation. It's definitely in their best interests. In contrast, of course, in the emergency setting, what we know is that emergency laparotomy, subdurals, fractured neck of femur, and all these patients can have delirium, different diagnosis, dementia, different prognosis, and therefore it will be quite common to operate in best interest in this particular setting. And that, of course, is worth bearing in mind. Importantly now to finish off with is how do we make surgery safer? So obviously there's preoperative optimization and prehab, which I'm going to talk about, intraoperative measures, which I'm not going to talk about because I'm not an anaesthetist, and that's something you guys know far better than me. And finally, post-operative care and support. So to iterate here, everybody knows already about exercise capacity in surgery, and it makes intuitive sense, doesn't it, that the fitter you are, the less likely you are to suffer complications and do badly after surgery. This much is evident from the work of older colleagues in terms of anaerobic threshold and cardiopulmonary exercise testing. Exercise capacity is also a marker of frailty. As you can see here, we know that people who can't exercise well are more likely to be frail. And this, of course, leads us to the conclusions that sort of prehabilitation programs are very likely and intuitive to be effective going forward. What we can see here, of course, is this general concept of making people fitter before surgery, so that they don't deteriorate so far and they make a more rapid recovery to independence and discharge after hospital. And we know that Prehab does clearly improve physical fitness. That much has been shown, and I don't think really is probably in doubt. What's more interesting and important is that there's emerging evidence that these sorts of measures with Prehab can actually improve real, meaningful outcomes after surgery. And although not every study has found this, we know that we are seeing studies come through which have shown in certain clinical settings, exercise training before surgery can reduce length of stay, it can reduce complications. But of course, old people aren't just cardiovascularly unfit. There's more to the frailty syndrome than that. And these sorts of figures from Edmonds and Frail School and others show us that it's more. And we know that nutrition also, optimizing that probably improves clinical outcomes. We know that things like pulmonary rehab also reduce complications, and that's obviously bundled exercise, smoking cessation, medical optimization of lung conditions. These also can reduce length of stay in older people, as indeed can alcohol cessation. And that's before we've even contemplated the murky web of psychological preparation for surgery, which again is an emerging feature and probably an important part of enhanced recovery and prehab of the future. So prehab in the future probably looks more like this, a multimodal system whereby there is exercise, there is nutrition, there is psychological intervention, but there's also medical optimization of things that can be optimized, such as cardiac, respiratory disease, anemia, glycemic control, blood pressure, smoking, and so forth. And this, I think, probably is where things are going in the future and makes a good topic, I think, for an exam viva. Ultimately, what that's looking like, though, is comprehensive geriatric assessment, which is what we do in our course for our daily practice. It's holistic, looking at all the factors that we can intervene on to improve outcomes for patients. And this, of course, is based in the evidence for fractured neck of femur orthogeriatric model, where this model of care at meta-analysis level has now been shown to be associated with length of stay, reduction in readmissions, reduced costs, and functional outcomes that are better for older people. In practice, of course, that basically means good, solid medical care across all the domains, which I won't really need to go into now because there's nothing particularly clever about it. It's all fairly intuitive. But what's really important now is that we know that these outcomes are probably looking like they're transferable beyond fractured neck of femur. And these references here, I realize you won't be able to write them down, but I'm just making the point that they exist. And we can see that length of stay and things like that in vascular surgery settings using the same sort of approach appears also to be improved. I'd also draw your attention very quickly before we finish to this sort of data from 2018, which is NELA, which indicated that the only independent parameter that was measured as this assessment of the data for NELA in 2018 that influenced outcome, time to anesthesia, seniority of anaesthetist, none of these things made a difference. What did make a difference, apparently, on the big data scale was the geriatrician review, made a difference to overall mortality. Now, obviously, that's not causative, it's just an observation, but it does make the point that there may be something in this in terms of systems where there's medical review embedded into these sorts of processes, and the care package may actually result in improved outcomes for older people. And this, again, is data from our trauma series in Bristol, where we've shown almost exactly the same finding. Geriatric assessment, whether it was proactive or reactive, was associated with reduced mortality in older people admitted with major trauma injuries over the course of 1 year. So in summary, older patients do badly. Complications are typically medical and occur late after surgery, not just in the operating theatre. But we also must remember not to forget the longer term outcomes, such as functional decline and frailty, which are really important from a consent perspective. Risk assessment is going to be fundamentally important in these sorts of patients, along with shared decision making between surgery, anaesthesia, medicine, and patient and their relatives. And also informed consent will be a way of dodging medical legal issues, hopefully, going forward. I hope to have given you a bit of a background in preoperative optimization and prehab, and a look towards the future in terms of what optimal pathways of care look like for older people undergoing surgery. And hopefully you'll begin to see that there is an emerging evidence base to support these models. Thank you very much.